Welcome to our series on substance use treatment. This series was designed to help our viewers better understand the advantages of a medical model treatment program. We'll begin this journey with 5 digital presentations, and we'll add additional sessions in the future with input from our viewers. This is the second presentation in our series, and it's titled Medication Assisted Treatment. My name is Kathy Hentrick, and I am on staff at Addiction Treatment Strategies, located in Edwardsville, Illinois, just outside of St. Louis. ATS is a 6-month intensive outpatient treatment program. We are a therapeutically based, medically assisted program which provides an extremely effective intervention for patients manifesting addictions. For this presentation, we have with us John and Carol Crum, founders of ATS. Again, this is the second in our series. And at the close of our presentation, we'll give you some information on obtaining CEU credit for participating today. So John, would you like to get us started?
Sure, Kathy, thank you. A couple things. What we would like to do is give you a little background and what I refer to as this is what we call our Think About It series as opposed to Feel About It series, which the whole concept is to get people to start thinking differently about how they see addiction and the impact that it has on people. So what I wanted to do to start with is to go back a little bit since 1971 when President Nixon declared the war on drugs. That's when this first started. And he also initiated the DEA. What was going on in the country at that time, obviously, was the war in Vietnam. We had a lot of campus unrest. We had National Guards troops on the campus as a result of some of it was the drug problems, Kent State shootings, and the belief on the part of the federal government that just about everybody on the university campuses was some type of anti-establishment drug-using person. So this came in conjunction with the JFK Community Mental Health Act, where we were started to move people from state institutions, which was in reality a large sanctuary for people, which was an effective way to at least keep people safe, moved them to community mental health centers, which had really yet to be started even in as early as the 70s. So we began discharging people, including substance abuse people, into communities without effective treatment. So as a result of that poor transition between the federal government and state institutions or state governments collaborating and integrating the concept, a lot of people fell between the cracks. So in the 70s and early 80s, what we have is a lot of people who are trying to get into residential treatment. And what we have here on the screen is just some data that relates to how people have been treated since then and continue to be treated in residential treatment programs. And remember, we have yet to have some type of a common agreement on what an addiction is with regard to a definition, what the outcomes we're looking for. But consequently, we continue in reality to help people considerably, but without an agreement on what should the outcomes look like. So what we have here is some data and statistics that says, okay, we have 242 patients in residential treatment. We know that in 3 days following treatment, 34% of these people are going to have a relapse, which means they're going to go back to using. Within 7 days, 45% of those people are going to relapse. Within 2 weeks, half of them will. And within 90 days of relapse, within 90 days, 60% of those people will relapse. So those are the facts. And part of this discussion originally was set out to be a podcast. And what we have on the second phase, Kathy, cold hard facts and some of the discussions that at some point we may get into when we do a podcast on this. What are the implications of these numbers? Does it really mean that as a result of all those people relapsing that we're not being a success? What happens to those people who are a success? How do we differentiate the people who are getting better from those that aren't? What does it mean in terms of what is the operational definition of residential treatment? There are hundreds and hundreds of residential treatment programs in the United States today. All of them who are doing something. Most of them are providing a good, safe environment for people for different periods of time. Yet going back to even 1971, when we declared the war on drugs, we still don't have a uniform concept of what are the outcomes that we're anticipating. So what type of treatment occurs in residential facilities? That varies from facilities. Some of them are cognitive behavior therapy based. Some of them are 12-step treatment TSF based. What type of treatment are people getting? What is the perception? What should happen as the outcomes? So going to that next page, Kathy.
Okay, so what is medication-assisted treatment really? Medication-assisted treatment is the use of medicines alongside counseling and behavioral therapies to treat substance use disorders. And the word alongside is extremely important when we're looking at the success of any type of a treatment program that uses medications. MAT provides a whole person approach to treat addiction to opioids, such as heroin or prescription drugs. It combines medications with behavioral therapy, psychosocial supports, and other wraparound services leading to the best outcomes. And again, the word it combines is, again, extremely important. MAT helps treat addictions by helping normalize brain chemistry, blocking those euphoric effects and relaxing physical cravings. And MAT, I think, is most importantly, it's not a standalone treatment. You know, MAT in reality is not new, as some form of MAT has been around since the 1930s. At that time, we really recognized two philosophies of treatment for substance use disorder, either total abstinence or some form of a harm reduction model. Models for treatment programs have evolved over a very long time, really since the 1900s. But because we are a drive-through culture, we really truly are constantly looking for, in every bit of these evolutionary changes to our treatment programs, a quick fix for a very complicated disorder. And so even medication-assisted treatment has morphed along the way. There are some very specific medications that are used currently in assisted treatment. There are 3 FDA-approved medications for a substance use disorder. Those are methadone, buprenorphine, and naltrexone. Buprenorphine, commonly known as Suboxone, and naltrexone, what most people know as Vivitrol. And according to the World Health Organization, methadone and buprenorphine are what's considered essential medicines. And what an essential medicine is really when the World Health Organization puts together that list, it's a minimum medicine list and needs for a basic healthcare system. So these 3 medications are, or at least 2 of them, methadone and buprenorphine, are considered extremely essential to any healthcare facility, any healthcare system. And when you look at those essential medicines, you see that there are things very simply like oxygen is one of the medical gases or one of the medications that is considered essential. Amoxicillin, hydrocortisone. So you can see that methadone and buprenorphine have really jumped into what's considered more common medications. For people struggling with addiction, the use of these assistive medications in combination with behavioral services can help sustain recovery better than therapy or medications alone.
Just for a second, Kathy, on that last slide, one thing that I would add to that, oftentimes people get very frustrated because of the concept of what does the word recovery mean. Oftentimes they believe that recovery means that you're cured and you'll never go back. If you would just alter that for a second in your thought processes, change the word recovery to heal. So it's not unusual for people, given the definition, to have a relapse, but that does not necessarily mean that the brain is not healing and the person is healing. So if you adopt a more holistic approach, what we know about the neurology of the brain is healing when you're not using, but that does not necessarily mean that you're not going to go back and use again. So instead of getting frustrated because you didn't recover and stay recovered, I said, you're still healing and getting better, because the amount of time it takes to get better is a lot more protracted than, like you said, in this drive-through culture, it's going to take 18 to 24 months to get stable again. I just want to put that in there.
Thank you.
So let's look a little bit more in depth at the 3 medications. I'm ahead of
I can
myself.
go on. All right, there we go. There you go, Kara.
So methadone is a full opioid agonist. That means it works by binding to opioid receptors in the brain. Methadone targets the same neural receptors as heroin and other opiates. Replacing an illegal drug with a prescribed drug, such as methadone, helps stabilize the lives of people who are opioid dependent. The aim of a methadone treatment is to prevent opioid cravings, to assist in complete abstinence from illegal opiates, and studies have shown that methadone maintenance decreases drug use, psychosocial and medical problems, and decreases criminal activity. It also improves the overall health status and social functioning.
I think it's important to even add at this point that a German chemist named Felix Hoffmann discovered a number of things. Methadone was one of those things. Also, heroin in the late 1800s and in 1937, they synthesized, were very successful in synthesizing methadone. So it's somewhat paradoxical. Not only did they or were they aware of the opiate itself, the agonist, heroin, also aware of what methadone could do for pain relief.
Second drug, buprenorphine, also brand name is Subutex, is a partial agonist. It means, again, by the way it binds to the opioid receptors in the brain, dependent on dosing. However, buprenorphine will only have increasing effects to a certain dose, and then its effects will plateau. Because of this, it's often less effective for individuals who are dependent on the higher opioid doses. So many studies have supported the safety and the effectiveness of buprenorphine in treating opioid dependence. Anything you want to add there, John?
No, I don't think so. In terms of some of the original fears of using buprenorphine, because it was used originally as a detox medication. Thank goodness it took a short period of time to realize that people could be treated effectively for like a methadone, a take-home dose, that you could treat people in a clinic on an outpatient basis. And if you managed or monitored their treatment very carefully, you could quickly titrate down from an initial dose, which may be up to even 24 milligrams for a certain period of time, and then titrate that quickly down to a maintenance dose, with obviously the overall goal being whatever the individual patient requires to be stable and healthy, then could serve for an extended period of time like any other pain relieving medication. So we continue to learn about how to use drugs and medication, and buprenorphine is definitely one of the best things that's come along in a long time.
The third one, naltrexone, common brand Vivitrol, works differently than methadone and buprenorphine in the treatment of opioid use disorders. It's an antagonist, meaning it binds to and also blocks opioid receptors in the brain. If the person using naltrexone begins to use opioids, naltrexone blocks the euphoric and the sedative effects. Naltrexone is available in long-acting injectable format. It's important to note that naltrexone can only be used with patients that have not used any opioids, and that includes the opioid-based medications, for at least 7 to 10 days. If administered before the patient has completely detoxed from opioids, that naltrexone can initiate serious withdrawal symptoms, something we really want to avoid. And one note here, we don't want to confuse naltrexone with naloxone. Naloxone is the Narcan that you hear about, and it's the short-acting opioid agonist used to reverse opioid overdose.
Okay, and John, I'm going to go back if I can for just a moment now that Carol has explained some of these here. So I'm going to just flip back if you don't mind. And I want to just go to this slide for a second and have our viewers really look at this. This comes from the Illinois Department of Health. And if we were to talk about this image, it looks like you have MAT, medically assisted treatment. And they're showing that it's a combination of behavioral therapy and one of these FDA approved medications. And as I spoke about before, that kind of drive-through culture of give me a pill, help me feel better, and and that's all I need to do. You can see here that the Illinois Department of Health is saying, no, that's not the case. The case is that this type of treatment is a combination of both. The behavioral therapy, which takes lots of time. We talked about that in our last presentation on substance use treatment programs. And then the FDA approved medications, one of those three. So let's talk a little bit now about who can prescribe these medications. So eligible prescribers include general physicians, nurse practitioners, clinical nurse specialists, certified RNs, anesthetists, and physician assistants. So right now, just about everybody can prescribe these types of medications. And, I want you to think of the pros and cons, of that. Yes, it's easy access for clients, most definitely. But there are also some disadvantages to that as well. So in April 2021, not too long ago, the U.S. Department of Health and Human Services altered the requirements for prescribing buprenorphine in order to expand access to medications like Suboxone. So what the U.S. Department of Health was trying to do was say, we know we have people out there who need this medication, and we need to get it to them quickly. So what they did is they relaxed those requirements for those prescribing. So the new guidelines created an exemption from long-standing federal training requirements for providers, meaning that anybody who provided did not need to go through that training that was required prior. The new guidelines also removed the requirement to certify their ability to provide counseling service. So if we go back to that image from the U.S. Department of Public Health, or the Illinois Department of Public Health, when they said that it takes both legs there for that treatment program, it takes counseling and it takes the medications in order to have success. When we removed that requirement to certify counseling services, what that meant is that many doctors were prescribing the medication saying, okay, we'll see you in 60 days, which was not the original intent of medication-assisted treatment. So under the new guidelines, providers may provide services to 30 patients without completing what was before an 8 to 24-hour training, depending on the type of license. So that elimination of training was perhaps, again, an expedient answer to the opioid crisis. And initially, it did make sense. However, as with most changes in program philosophies, as we all know, the latest changes always seem to stick. And what that means is we have a larger number of providers without even an 8-hour training. Perhaps the most significant component is elimination of the requirement patients be involved in counseling treatment. Currently, that doesn't necessarily have to be the case. And that, again, is the most significant component of medication-assisted treatment.
I've never
Medication.
seen a time when
Go ahead, John.
it's been more important to establish a firm collaborative relationship between physicians and counselors other than treating with the opiate epidemic. I understand totally why the federal government relaxed the guidelines, because we're losing 100,000 people a year to overdoses, and definitely getting more providers was essential. The downside is, or the paradoxical side is, most likely what caused the opiate epidemic in the first place is that we weren't doing a very good job of managing how many opiates we were giving to our patients. Consequently, we didn't have the supervision, and they developed an addiction prior to the time that we knew they had an addiction. And my concern is that we need to be more carefully regulating our patients, or having patients be accountable for their guidance and supervision as a result of the collaborative relationship between the physician and hopefully the counselors who are seeing these patients at least weekly. there's no way in the world, in my opinion, that you prescribe a medication like Suboxone that has the potential to save lives and hurt lives at the same time, and give a 30 or 60 or 90-day prescription for that medication without having a patient during regular urine drug screens, monitoring for other substances in their systems, to be safe in providing that medication to patients, so that we can do the behavioral treatment programming while we collaborate.
Thank you, John.
Yeah, I think the main reason why we need some type of medically assisted treatment is that it's not uncommon for people to report the patients who come here, and the patients that I've seen, is the reason that they don't quit using a drug is because of the painful side effects when they go through withdrawal. So the good part about medication, if you will, it using analogy, it softens up the clay so that it can become more malleable in the brain, so that they don't have the terrible side effects, so they can at least think rationally about what's happening. Oftentimes people look at the second statement there, blocks the euphoric effects of alcohol and other drugs. By the time someone's been using medications or drugs for 2 or 3 years, it's no longer about the euphoria. It's the maintenance effect of that drug to keep them normal. So they can't give up those feelings of normal, because when they go into a withdrawal, it's extremely painful process. So the medication is the stabilizing effect, at least initially has to be the stabilizing effect. Then that medication should also be used for extended period of time, which I'm talking about extending more than 30 days. It has to be used to slowly check the impact of that medication on the person's neurology, so that they don't rebound and have depression, bipolar, ADHD symptoms resurface just because they got off of a drug. So medication-assisted treatment is essential to the success of anybody on opiates, for sure.
Yeah, and it's no different than if we had a backache and we were sitting in a meeting at work. If my back's aching, I'm not thinking and doing the hard work that I need to be doing for my job. And as they're sitting and coming into counseling, coming into therapy, if they're hurting, they're not attending the way that they should be attending to get the most out of their counseling sessions.
I think the next 2 slides, if you look at them carefully, can be somewhat overwhelming. But if you take them apart, what it shows, first and foremost, you have opiate receptors in the brain. Otherwise, opiates wouldn't do anything. So you can ask, why do we have opiate receptors in the brain in the first place? Because they mediate pain. That's a good thing. So what's happening with the impact of opioids, the receptors are kind of a lock of the opiates, and then that turns on the receptor, resulting in intoxication. When the opiate has increased, it unlocks that receptor and then basically floods what we're talking about is the nucleus accumbens in the ventral tegmental area with dopamine. So the medications are used to fill that opiate receptor and then help prevent the opiate misuse and withdrawal symptoms, so that basically we're tricking the brain, if you will, or we're tricking the cognitive awareness into believing that you have an opiate in your brain, so that you're not required to have that opiate anymore, while we begin to treat you without developing a further dependence on an increasing amount of an opioid. So that then allows us to treat patients and slowly titrate them down from whatever level of an opiate use they were having on a daily basis. I think the second slide is a little more complicated, and we kind of stuck that in there for a reason. What you see is the purple nucleus accumbens in the ventral tegmental area, and on the green on the side. That's the current theory of intoxication, opiate intoxication. It's the drug reward pathway. So that's the flooding of dopamine between those 2 systems, and the inability of the prefrontal cortex, the limbic system there, or the prefrontal cognitive system, to downregulate that. Well, what you can see there, it's not just the opiates that can flood there. It's alcohol, PC, the MDA receptors, everything can be upset as a result of altering the chemistry within the neurobiology of the brain. And then you can see all of those things that impact, and it gives you almost a 3-dimensional view of all the different ways that things connect to the nucleus accumbens and the ventral tegmental, which includes alcohol, nicotine. Some of you may be familiar with Chantix or varenicline. That's very successful in decreasing the compulsion to use nicotine. All those other drugs in there, all those other proteins and neurotransmitters are impacted by everything that we add to the system. So it's not a closed loop. In reality, it's an open loop of neuronal firings that sometimes don't even need or require an additional substance added to the system, because once the system is there, it basically reverberates. It can go and it can bounce and it can reignite itself without adding new systems. That's what makes addiction so complicated. It does not necessarily require more and more of the drug, but as I use more and more of the drug, my tolerance increases, which means I also need more of the drug. So it's a very cumulative building process that I believe has to be monitored very, very carefully.
So we can say, what are the benefits? There's been a decrease in opioid-related overdoses with the use of medications, decrease in illicit opioid use, increases in social functioning and retention and treatment, decreasing criminal activity, increasing the outcomes for fetal survival. But while Narcan will have significant immediate impact, it hasn't done anything about the structure and the function of the brain. Remember, the addiction has changed the brain. So for that reason, we can't do it with medication alone. Something else has to occur besides just medication. The history for medication-assisted treatment and abstinence-based treatment are quite different. Traditionally, individuals using medication may not have been thought of as abstinent and thus weren't a viable part of the larger recovery community. John, I think there was something else you wanted to add there.
Yeah, I think there are two things in here that need to be looked at in terms of original medically assisted treatment occurred when physicians first started prescribing medication. Now medically assisted treatment is known basically as it relates to the opioid epidemic. In fact, a part of this grant with CIF and ARCOR is as a result of the Surgeon General, the Secretary of Health and Human Services, and Dr. McCants Katz from Substance Abuse Mental Health Service Administration coming to visit the ATS clinic about 2 years ago. And when they looked at our protocols for medically assisted treatment and what we were doing with a bunch of elected officials and judges and things in our conference room here, said we don't understand how it is that you're about 20 years ahead of the country in developing protocols. And what I told them that time is we're doing what science says we should be doing. And I said, it's really, it's a mark on the 3 most influential people in the world of substance abuse. When they visited the clinic, I said, you people are the most influential people in the United States as it relates to medically assisted treatment and drug recovery. We need to move away from the 75% of treatment programs who continue to use the 1930 approach to move them towards a science of what we know is documented in terms of research shows that medically assisted treatment is a fabulous tool for everybody to adopt as a program. We're always going to have resistance whenever there's change. There's a big difference between what people believe to be medically assisted treatment, medically assisted recovery. There are those people who continue to believe that persons who go to AA shouldn't take any type of medications. That's a component of resistance. And if we can do a little more education and a little more information as to the impact of MAT, then I believe we'll begin to turn some of the corners as it relates to both MAT and MAR.
Within the community of recovery, our community, medication-assisted recovery, MAR, is the preferred term since it emphasizes recovery. MAR may also indicate the individual's commitment to engage in recovery supports as part of their long-term path to recovery, in addition to using prescribed medications. This term offers a non-stigmatizing framework that bridges the two different philosophies.
Yeah,
John,
yes.
go ahead.
The
Yes.
stages of medically assisted treatment, originally when it was used in hospitals, people had to go to the hospital for 3 or 4 days to be induced. I think we were still learning about that curve, even in the induction phase. People had to be free and clear of all substances in terms of opiates for sure, for at least 2 or 3 days. And that can be true if you need to go through medically assisted treatment. What we found is that as a result of people not being able to get to a hospital, and physicians, now that there are so many more physicians who are using Suboxone, even on an outpatient basis, it doesn't take long to figure out, once you develop a relationship with a patient, what you can do is what's called a clinical opiate withdrawal scale. And it's an 11-point scale where you look at that and you have some biological signs in terms of pupil dilations and shakes and nerves, and you can look at that. And when the person meets a threshold of a minimum or equal to 7 or greater, you can probably start the induction of 2 milligrams of Suboxone. I'm not the physician, but I'm just knowing that's what they do. And then they can increase that depending on how patients respond to that. Now, what we do know is that every person responds differently to the induction process. And most often, the patient can tell you when they're into moderate severe withdrawal. Elementary withdrawal or beginning withdrawal, maybe a low on the Cow scale of a 7. Our physician prefers to wait till they get to a 12 or a 15 where they're in moderate severe, because we don't want to get where we have a substance abuse withdrawal problem in terms of that's very uncomfortable for 3 to 4 days. So we want them to be stable enough where he can induce the process and then manage that based on their reaction to the initial dose. And then after we get whatever the titrating dose or the stabilization dose is, then we monitor them here. We monitor them daily for the first 2 or 3 weeks. We do urine drug screens, do all that stuff to make sure we check on them. How are their vital signs on a regular basis? And then as they stabilize, then the physician can make the determination of what is it going to take for long-term maintenance. We have patients who've been in our system here for 4 or 5 years, and they're down to about 2 milligrams of Suboxone on a regular basis. But they're extremely stable. They have their jobs back. They have their wives. Their health, legal, vocational relationships are better, and they're being maintained on an extremely low dose of Suboxone. And at some point, hopefully, we would see that they may be able to get off of Suboxone, primarily because there's a cost associated with it. So if we can get off the medication, that would be fine. If not, they may be maintained, just like Kathy says, relative to lower back pain. They may need to be on Suboxone for an extended period of time.
Okay, and just like everything in addiction, there are stigmas and myths associated with medication-assisted treatment as well. The FDA-approved medications, combined with psychosocial services and recovery supports, are really the gold standard for opioid use disorder treatment. The approach has been proven to reduce drug use, reduce risk of overdose, prevent injection behaviors, reduce criminal behavior, but still there's stigma associated with it. In the past, MAR has been referred to as drug replacement therapy, often leading to a lot of disagreement about whether people on MAR could truly live a substance-free life in recovery. However, medications are essential for some people to reduce cravings and withdrawal symptoms and to help them avoid future opioid misuse and engage in long-term recovery. So some of the myths that we hear quite often when someone is receiving medication-assisted treatment is that medication-assisted treatment is not a legitimate pathway to recovery, which can be no further than the truth. You are only substituting one addiction for another. And again, so not true. Medication-assisted treatment means someone is not practicing abstinence. And what's sad about that is that at times, people who are in a medication-assisted treatment program can even be shunned by their peers who are in the recovery community. because they feel that if you're not abstinent, you're not truly practicing recovery. So it is, it's a shame that that's kind of the mindset and one of the stigmas that come with this type of treatment. And some people believe that if used, a medication-assisted treatment should only be used for a short time. So currently, there's no research to support the use of a predetermined length of treatment for medication-assisted treatment. Decisions about length of treatment and any adjustment should really be made between an individual and their prescribing physician and no one else. The stigma should not determine or anyone's comments in the recovery community should not determine how long someone is on these medications. Many issues involving MAR come from someone stopping their prescribed medication too quickly and when they're not quite ready yet. You know, as we've talked about, the psychosocial side of addiction treatment, the psychotherapy side of that is an extremely tedious process, and it takes time and it takes patience. We don't want to stop these medications too soon. When we do that, when this happens, a person's tolerance to opioids drops dramatically and can actually put them at risk for a life-threatening overdose as well. So some issues created by a lack of understanding, and that's exactly what a myth is a lack of understanding. Go back there. 1/3 of persons seeking treatment for a loved one will actually refuse to accept care from a caregiver using medication-assisted treatment because they believe in that abstinence philosophy that you cannot be on any type of medications, any drugs, if you have a substance use disorder. It's even apparent in recovery housing options. Those may be limited due to needed coordination efforts with prescribing physicians. So if you're in a sober living facility, unfortunately, there are sober living facilities that will not accept patients who are on these types of medications. And not so much that they don't believe in the medications or see the benefits of them, but that they just don't have the prescribing physicians to monitor those medications.
I think one of the most significant problems we have is recovery housing for sure. That's probably the largest problem we have to take care of people who are unable to take care of themselves, especially safe and supervised housing. I think we're very fortunate in this area to have Our House in Charleston, where I think people do an excellent job of maintaining safe and supervised housing. People get better. And it's not just the clinical approach of what they do and what you're going to find when you provide a service like this. It's about the staff. The staff knows what they're doing, and people get better when they go. So check out Our House. I think this is the single best thing that we've done in a long time for the DEA is to allow practitioners to dispense 3 days of medication to get people. It buys us time. It helps people who can leave rehab and find a place to go. It gives them at least 3 days to at least try to get hooked up with a physician or get hooked up with someone who can provide you treatment, even though that's probably not long enough in my experience, because they may have a waiting list of a week or 2 weeks or 3 weeks or 5 weeks, but to recognize that physicians need to be able to prescribe at least a 3-day of a drug. It's not atypical to be discharged from a hospital without pain medication, and you may be discharged on a Sunday and find your doctor on a Monday or Tuesday, and you don't have pain medication. This works exactly the same way with someone who has an opiate addiction. Even though you have discharge plans that say we may see you the following day, your physician may not be able to see that patient for 4 or 5 days. So then we have a real dilemma that how do we make adequate transition for our patients to get from a residential treatment facility or get from a hospital so that they can see the physician with 3 days to continue to maintain their health. So I think the 2023 DEA decision rule is a great way to begin to make changes in the process. I think opioid withdrawal is what happened to people when they go without a source, when they begin to withdraw. They know it right away in terms of it can occur anytime that the opiate agonist or buprenorphine or something like that can be used. In terms, the main key or concern that we have with opiate withdrawal is precipitated withdrawal. If someone comes in here and they have been using opiates and we do urine drug screen and find out there's still something in their system, we can go to the second slide there, I think, Kathy, in terms of some of the withdrawal symptoms that we're checking for. And this is what we're seeing is someone comes here, they have trembling and tremors, they may have muscle pain. It's not unusual that they're cramping, they're unable to sit straight, they're sweating, they're agitated. It's not unusual to have people nausea and vomiting, depression. All these things are symptoms of withdrawal. That's when the COW scale comes in, the clinical opiate withdrawal scale comes in, to make sure that people are manifesting some of at least some of these symptoms above a 7, greater or equal to a 7, so that you don't initiate precipitated withdrawal, which then that's probably worse than withdrawal symptoms on its own, because once we precipitate that withdrawal, we're going to be knocking off all the opiates from those receptors, and they're going to get very sick for 4 or 5 days. So we don't want that to happen. So make sure you use the COW scale as a reference, and then talk to the patient in terms of what is their general use of time before they go into withdrawal, so we can work together to get the patient healthy. I think that's the main thing on withdrawal symptoms, Kathy.
Okay, thank you.
This is always a problem. Diversion has been a problem with opioids, and well, not just with opioids. Diversion is a problem with medication. It's not atypical if someone has a medication and your brother, sister, aunt, or someone has a headache or headache medication or sleeping pill, to borrow sleeping pills from there. That's called diversion. So this is extremely common with people with opiates because there's an extremely high street value for Suboxone. I have heard Suboxone going for as much as $75 for a 2 milligram strip. That's if somebody is really, really sick, and they'll do anything on the street. So I think with the DEA Act in 2023 of increasing doctors' availability to give 3 or 4 days, hopefully that diversion of those medications will decrease, and we'll have more and more people who enter treatment on a regular basis. Obviously, I think we need more treatment providers. We need more quality treatment providers, and we certainly need more physicians collaborating with mental health centers and substance abuse treatment centers to work with patients.
And John and Carol, do you have anything to summarize, our presentation here for our viewers?
Yeah, I think people have to be patient. The system is obviously overwhelming. As long as we're moving in the direction where we're losing fewer people, I think the end that we're probably losing, if you will, the 1971 war on drugs, is definitely on the legal end of there. We're bringing so many more drugs into the country. It's hard to prevent that. So I think we need more and more treatment facilities, and they need to be easier access. And I think it starts with competent mental health workers providing housing to people. And I think people need to be able to move in and out of a system from a hospital to housing to outpatient to housing to hospital to outpatient. I think they move through the system, and we need to begin to recognize that there is no quick fix for addiction. Most people should be in treatment probably for a minimum of 2 years. Minimum 2 years.
Wonderful. Thank you very much. All right. Real quickly, and if you've enjoyed our presentation, we want you to join us again. Again, we'll have a minimum of 5 of these to start, and then we'll gather some input to see what else it is that viewers are interested in and would like more information on. In order to earn CEU credits for participating in these workshops, please complete the following and email it to Carissa Vandenberg Clark. She is the assistant professor at Family and Community Medicine at St. Louis University. And I've given you her email address there. And what we're asking you to do, our goal here isn't for you to just regurgitate this information back out, but we really want you to think about your attitudes, your practices, and how this new information coming to you affects that. So we're asking you to write a 2-page reflection paper on how your thinking has changed after watching this presentation. What attitudes have changed? What practices will you change? But we do need you to cite evidence from the presentation throughout your reflection paper. And in the subject line, when you email that reflection paper to Carissa, please put CEU request for medication-assisted treatment. And she'll get that information back out to you. Okay, thank you very much for attending today.